Can you hear me okay?
Yes.
Yes, Mike, we hear you.
Okay, thank you. Thank you for your patience.
Thank you.
So I think we should, our structure today is we're going to have 10 minutes of comments and presentations by each presenter. Following that, we will have some moderated discussion. And if we have some time, maybe some discussion questions from our remote audience. So we will start first with Fahmy. So Fahmy, the floor is yours.
Mike, thank you so much, and colleagues, it's a pleasure to join you all today, and let me share with you some of the learned lessons that COVID-19 pandemic has taught us about mental health and psychosocial support. First, I think one of the key things reaffirmed during this pandemic is the cross-cutting nature of mental health and psychosocial support. Its relevance across all sectors and across all clusters in humanitarian system, and the need for multi-sectoral collaboration for its scale up. It's not the function of one sector. It's not the function of health or protection alone, or education alone, or nutrition alone. It's function of all of us. This was emphasized by all heads of many United Nations agencies in the joint interagency call for action, which was released in December last year, and reflect really a shared vision among all UN agencies. Colleagues, mental health and psychosocial support is not only cross-cutting across sectors, it's also cross-cutting within sectors. So when we talk about public health emergency, mental health and psychosocial support is relevant to a range of public health emergency pillars, from partners coordination to risk communication and community engagement, to case management, to continuation of essential health and social care services. Another thing which was emphasized during the pandemic is the critical role that the interagency coordination represented by the mental health and psychosocial support reference group can play and should play in the global humanitarian system. The group acted very early in the response as a global reference point for mental health and psychosocial support, building on learned lessons from emergencies which was there. Some of them were decades ago, like H1N1, where mental health and psychosocial support was a component, and some were few years back, such as the Ebola response, where we documented the learned lesson. We were starting to have global coordination calls among interagency actors as early as January last year. We published our first interagency product as early as February last year, which make mental health and psychosocial support having really a global consensus among different actors. Innovation does not necessarily mean information technology. Reaching out to local communities and challenging to reach areas can be achieved rapidly through simple, innovative, high quality and cost-effective and practical tools that not always necessarily IT-based. An example of this is a children's storybook on COVID-19 that was developed by the ISC MHPSS reference group and was available around 1 year ago, early in the response. Through inputs of children and families from more than 100 countries, the children's storybook, My Hero Is You, has been translated so far to 141 languages and converted into more than 50 multimedia adaptations. A very simple and heartwarming storybook for children COVID-19 teaches children around the world how to protect their well-being, themselves and others, and became one of the most translated resources by the United Nations and one of the most translated books, and reached 167 of the 193 UN member states in their official languages, including in hard-to-reach areas and population. Another key observation is the growth of country needs for mental health and psychosocial support coordination. This can be really remarkable during global events such as this pandemic. The number of country-level mental health and psychosocial support technical working group has increased from 23 countries in March 2020 to reach in December 2020, 53 countries. The learned lessons are that country-level MHPSS experts on coordination is essential, and the newly established interagency mental health and psychosocial support surge mechanism, which served so far more than 20 countries, was key in filling some of these gaps. Again, another learned lesson is the need to make materials available for global dissemination. For example, the need to translate materials into multiple languages. The basic psychosocial skills for COVID-19 was translated into 30 languages. Also, the need to develop inclusive formats of mental health and psychosocial support materials was emphasized. There is an ongoing project by UNICEF on this, and the IC MHPSS reference group has produced products in Braille or in sign language to support mental health and psychosocial needs of people with sensory disabilities. Additionally, the need to develop resources in adaptable and create mechanisms to support the adaptation. We developed some resources and adapted it for indigenous population, mental health and psychosocial support in collaboration with many partners. We also learned that operational adaptations are essential to implement multi-sectoral mental health and psychosocial support. And in June 2020, we published a document focusing specifically on operational consideration across sectors. We also learned that there are gaps in technical resources, particularly for specific age groups. And in this emergency, it was for one of the most vulnerable groups. We did not have before this emergency many resources focusing on mental health and psychosocial support needs of older adults, for example. We developed one during this emergency, but there is a need to focus on these very vulnerable groups that will continue to have needs, not only in these emergencies, but also in future ones. Finally, I want to share with you that in the coming World Health Assembly at the World Health Organization, mental health and psychosocial support is included for the first time on the agenda as requested by member states, and it will be discussed in the context of emergencies, and all that was requested by countries. The WHO member states emphasized the importance of integrating mental health and public health emergencies at the WHO Executive Board meeting in January this year, through endorsement of a decision focusing on scaling up mental health services and psychosocial supports as an integral component of any public health emergency response, preparedness, and recovery. As I said, between January and March, we have assessed countries' integration of mental health and psychosocial support. 90% said they have integrated. 64% of countries said they have active multi-sectoral MHPSS coordination platform. 82% are implementing mental health and psychosocial activities. 49% of countries have been reporting that they are allocating funds for mental health and psychosocial support activities. But the bad news is that only 20% of countries have reported that they have allocated full financial resources required to implement their mental health and psychosocial support plans as part of COVID-19. So there are still gaps. There's still need for more investment, both in financial and human resources at country level, but there is recognition for the area. And countries including USA, Canada, the EU member state, Thailand, Chile, Bangladesh were among the sponsors of this important decision that will be presented, and others in this important decision that will be presented to WHO governing bodies in this month, which represent the first ever decision by governments on mental health as part of public health emergencies. And the good news, at the same session, countries will also be discussing having set of indicators, including mental health and psychosocial support preparedness indicator, to which they will be reporting for the first time on WHO every 2 years. Thank you.
Thank you so much, Fahmy, for those very helpful remarks and that global overview from where you sit at WHO. Really appreciate your interagency perspective and great strength of emphasis on coordination. We get nowhere without it. It's always an Achilles heel for us. So turning next to Zeinab Hijazi, we're going to be able to hear from her perspective as the UNICEF specialist on mental health and psychosocial support in emergencies. So welcome, Zeinab.
Thank you so much, Mike. And so I think it's really important, and really building on what Fahmy was saying, to understand and acknowledge that the MHPSS field has over a decade of experience in integration within the humanitarian response system, with a growing base of evidence, standards, and best practices to safeguard mental health and psychosocial well-being for all children, adolescents, parents, and caregivers, especially in the most vulnerable populations. But we're still far behind from where we need to be. And while mental health is drawing, especially now, lots of attention globally and from the humanitarian community, it remains severely underfunded and misunderstood. So consider what we know about the scope of the problem. We know that 10 to 20% of children and adolescents experience mental disorders, while 1 out of 4 children live with a parent with a mental health condition. One of the most extreme manifestations of poor mental health is suicide, which claims the lives of close to 800,000 people every year, with many more attempting to take their own lives. And half of all mental health conditions start by age 14 and 3/4 by their mid-20s. And these are alarming global statistics. And we know that the risk for mental health conditions and psychosocial problems among children and adolescents is exacerbated when they are exposed to poverty, violence, disease, or humanitarian crisis. Sadly today, Mike mentioned in his introduction as well, we do face an unprecedented scale of humanitarian crisis and migration. The number of children who are living in a conflict zone has increased 75% from the early 1990s, and we find that children are more at risk in conflict now than at any time in the last 20 years. And this experience is sadly a reality for too many children today. We know that children thrive when they feel safe and protected, when family and community connections are stable, when their basic needs are met. Unfortunately, humanitarian crises, they disrupt many of the foundations that assure children's mental health and well-being. Children are suffering not only extremely distressing experiences during an emergency, but also cumulative stress due to daily life adversity, insecurity, and deprivation, especially in protracted emergencies like we're seeing in Syria and in other conflict zones. Humanitarian crisis, of course, also puts parents and caregivers under mental and psychosocial duress. We've seen this quite clearly in the COVID pandemic, which can also prevent them from providing the protection, stability, and nurturing care that their children need during and after an emergency. And really, the failure to address these issues can be detrimental to a child's development and can hinder their ability to contribute fully in their societies. In schools, children are unable to learn effectively if they are facing high levels of stress, which limits their ability to develop the essential skills they need to get on in life. And this is the field in which MHPSS operates. MHPSS is this catch-all word for a range of services aimed at safeguarding or promoting psychosocial well-being, as well as preventing and treating mental health problems. MHPSS interventions can help by reducing risk factors and increasing protective factors at all levels, placing the child at the center and supporting not only a child's individual factors, but also factors in their family, their environment, their culture, and their society that in turn have significant impact on the well-being of the child. And the good news is, we know what works. UNICEF's approach to mental health and psychosocial support is twofold. First is bringing together different actors at different sectors as entry points for addressing mental health issues and reaching those children, adolescents, and caregivers who are most in need. Second is recognizing that children's well-being is linked to their environment and that it is informed by the social ecological framework. In other words, children's development and well-being are embedded in a child's own context and experiences tied to relationships with their caregivers, their friends and families, supports in schools and communities, sociocultural influences, as well as broader political and economic factors. And these approaches are foundations to effective MHPSS programming, which requires a range of services with functional referrals between community supports and clinical care, mainstreaming across humanitarian sectors, including health, nutrition, education, and child protection programs, so that MHPSS is integrated into schools, health centers, and other community structures, realizing that one size does not fit all, and providing tools for contextualizing and localizing interventions and processes, reaching those children and families who routinely fall through the cracks in services, those with developmental disabilities, serious depression, suicidality, or substance use and behavioral problems, and acting early in the life course and investing in early, responsive, nurturing, parenting, and quality learning to build children's resilience, and thus supporting and not deprioritizing caregivers' own mental health, which in turn supports children in their own coping and with what they've endured in the midst of a humanitarian emergency. And of course, at UNICEF, we work, similar to our partners, we work very closely with governments at all levels to ensure that investments in mental health are being made. Fahmy spoke to this quite clearly. But it's important that we're not thinking about investments in health services only, but across the various ministries and sectors, since MHPSS is not a health sector responsibility alone, rather a multi-sectoral responsibility. Now, MHPSS in humanitarian settings, especially in COVID, in times of COVID, has served as an important reference and a guide for how we approach mental health and well-being across settings. The field has really moved away from being overly focused on psychological trauma or post-traumatic stress disorder and on specialized treatment by mental health clinicians from high-income countries, and has really moved towards a more inclusive approach, one which recognizes the scope and significance of different types of culturally shaped mental health problems, and one which seeks to develop existing strengths and build capacities over time in order to integrate mental health care within existing health, education, and social and community structures and services. In fact, the primary purpose of the interagency standing committee guidelines on MHPSS, which were launched back in 2007, was to give these concrete strategies for MHPSS responses through a multi-sectoral framework to enable not only coordination, but also to clarify how different approaches to MHPSS can support and complement each other. Now, fast forward to 2020, the UN Secretary General, in alignment with the ISC guidelines on MHPSS, outlined in his policy brief on mental health and COVID response a whole of society approach to promote, protect, and care for mental health. This means that mental health, again, is not only a health sector response, but must be collaborative, multi-sectoral, and span across health, social welfare, education, gender, and other sectors to truly be effective in addressing mental health and psychosocial needs. And of course, something else that we've relearned in the last year is that humanitarian conditions present substantial challenges, but they also present tremendous opportunities to meet the moment head-on, opportunities to raise awareness, to leverage political commitment, and affect policy change, as well as to mobilize resources, drive investment, and ultimately bring measurable and meaningful change to children and families. And in closing, the sheer scope of the challenge demands a significant increase in response. And for MHPSS, it's important that we not only scale up what works, but also scale deeply with quality interventions to have a real and sustained impact for children. Until now, the impact of emergencies on children's mental health and psychosocial well-being has remained relatively neglected in both humanitarian responses and international development, and this really needs to change. We must unite. Reducing the burden of MHPSS challenges requires collaboration among a wide group of stakeholders, including nations, donors, and organizations who must all work together if we want to see real lasting change. We need to be amplifying the powerful and persuasive voices and action of youth, caregivers, and service users in communities who are increasingly leading transformative change in their own communities. We must fund our efforts at a level that is equal to our commitment. We need greater investment in mental health at all stages of life, especially for children and youth who are affected by armed conflict, those exposed to violence and severely distressing events. We must act quickly and decisively on many fronts, not simultaneously. We need to ensure that children, adolescents, and caregivers and families have access to services and that their human rights are served and protected by laws, policies, and new social norms. We know what works to safeguard children and families' mental health and psychosocial well-being in humanitarian settings. So it's really time to unite around these proven strategies, fund them adequately, and act collectively. Thank you.
Thank you so much, Zeinab. Your emphasis on the multi-sectoriality of the work on mental health and psychosocial support, as well as on the ecological and whole society approaches that are necessary are really timely. Thank you so much for that. So third, we will hear from our colleague Ananda Galapati, who sits in Sri Lanka. Welcome, Ananda.
Thanks, Mike. It's interesting. We connected briefly about what we were talking about, but I do think that there's something in the air because I did realize that both Fahmy and Zeinab were going to emphasize the multi-sectoral nature quite as much as they have, but I think that in fact is what I particularly wanted to focus on, and hopefully I can provide a little bit of an additional context for the rationale that I see for this great need for greater collaboration across different sectors. And I think, you know, a broad humanitarian forum like this, you know, as practitioners from the, I think, still relatively niche field of MHPSS, I think this is a good place to make our pitch for this and to reach out to colleagues in other sectors. So now the fact that the COVID-19 crisis has actually affected significantly most countries and communities around the world has, I think, also really laid bare the fact that, as the metaphor goes, we may all be traveling through the same storm, but we are certainly not in the same type of or quality of vessel. And we have seen the importance, and many of you recognize the importance of these underlying inequalities and structural factors that have contributed to both the strengths and the vulnerabilities in, for example, our respective health systems or in our economies at both sort of national and local levels. And the significance of these sorts of determinants has also been very visible when it comes to the mental health and psychosocial impacts of the crisis on individuals, families, and also communities as a whole. So social determinants have really shaped people's experiences of the pandemic, whether this be in terms of kind of exposure to serious stressors such as loss of income, exposure to violence, risk of dropping out of education, increased risks of contracting COVID-19, and the consequences socially of the stigma of that. And these social determinants have also been very powerful factors in not only causing but also mediating the distress, difficulties and mental health conditions that have affected so very many people during this period. And the report that Mike referenced in his opening remarks that the Red Cross put out in late last year, and also what, you know, colleagues around the world have been sharing with us throughout the past year, really emphasizes that, you know, people in settings of adversity such as conflict, disaster, or chronic poverty have experienced suffering that really is at the intersection of many different kinds of determinants that undermine their well-being and their resilience. And I'd like to sort of expand our view to also reflect on the fact that movements like Black Lives Matters, which have global traction, have also drawn attention to the importance of addressing also some of the effects of historical injustices that have sort of social and political and material consequences, both areas of work that seek to address at the source some of the harm and vulnerability that contributes to mental health and psychosocial suffering. And we see this also not just at the global level, but also at country level. We see MHPS practitioners working with actors that are providing people with relief during the pandemic, or addressing food security issues, or indeed domestic violence. And this kind of intersectoral work requires strong and kind of open engagement with practitioners across the different fields, and the kind of creation of mutual spaces to acknowledge the contributions of other fields. We need guides and interlocutors that can help our understandings and skills and experience within our field to infuse this into the operational frameworks other sectors employ. The field of MHPSS really needs champions from within other more well-established primary stakeholders, be they affected community members, local services, or governments, can adopt to ensure that their actions across a range of fields are contributing to the well-being of their people and minimizing their suffering, including, crucially, through the addressing of the key determinants and challenges that are vital in their specific context. And I cannot emphasize more the importance of what Zeinab said in terms of the way in which we understand how that context impacts and mediates. So for me, really, to watching the scale of the COVID-19 pandemic overwhelm many of our best efforts in the field. Colleagues, we've seen heroic efforts, and many of the responses that Fahmy also described in his listing of the lessons learned have been attempts to try and address that gap, and very sort of effectively so. But for me, the challenges that our field has faced has in meeting the scale and kind of complexity of those needs has reaffirmed that foundational principle from the ISC guidelines, that all, as my two colleagues have said, all key humanitarian, and I would include also development sectors and stakeholders, have a vital role to play in securing the mental health and psychosocial well-being of affected populations, and that we will not achieve our goal unless we invest more in finding better ways to work together. So I think, in conclusion, I think we, as Zeinab said, we've made progress. We have certainly very promising approaches and initial guidance that we're evolving. But I think that we need much more in terms of truly integrating the MHPSS objectives into the fine detail and operational practices of other actors and the work that they do, that for us addresses the things that make a difference in the lives of people we're trying to serve. So I see this as the key work for the field going forward. Over from me.
Thank you so much, Ananda. Your multidisciplinary approach is really the way that you have historicized the work as well, and encouraged us to think about structural violence is highly valuable. So it's my turn next, and I'll try to be as brief as you have. So I wanted to help us think about mental health and psychosocial support and localization, and the importance of prioritizing local power, collective agency, and resilience. And I want to offer a critical perspective that may help us to reimagine and transform humanitarian work on mental health and psychosocial support, with a special emphasis on the increasingly widespread long-term crises that we're seeing today. I wanted to start with a brief focus on power and knowledge. That's really, I think, nothing new. But the humanitarian system embodies a large power asymmetry that privileges the global northern actors, people such as myself. Wider strategies for humanitarian aid and development and for funding come mostly from the global north. Humanitarian mental health and psychosocial support projects are typically designed and the implementation is led by international agencies such as NGOs, UN agencies, governments, and so on. Local people are often implementing partners, sometimes even referred to as beneficiaries. In this scheme, local people have, I think, too little agency and are even made dependent in long-term settings that would have provided for much greater participation and for the psychological dignity that comes from having a voice and having an influence on the decisions that are made. So we need an approach that provides more of that and enables local ownership. Second, with regard to knowledge, it is primarily Western categories that guide the definition of the problem. We see this in the use of categories from the DSM or from the ICD, and those are hugely useful. But it's also true that local people have their own idioms of distress. And sometimes what happens is we focus so much on outsider approaches that we don't take the time to build the trust and to really listen to local people in a way that helps them learn about the local idioms that are so important to their cultural identity, their well-being, and their social meaning. So out of this, I'm going to urge that we need more bottom-up approaches that feature local leadership, collective self-help, and local solutions. And that's going to challenge us and invite us to engage more deeply with communities, and in a way that does not privilege us as the only holders of knowledge. We do hold valuable knowledge, but local people are holders of valuable knowledge. And with regard to local solutions and local action, I think we need to ask ourselves, can refugee-led groups do a lot for themselves? There's some really excellent groups, for example, in Uganda, that are helping adolescents and pre-adolescents get back to school. And they're doing that on their own initiative. And I think it's much more sustainable when it happens that way. With regard to youth support, some recent work I was doing in Eastern Ukraine led me into contact with a young woman who unfortunately had been cutting herself and was really quite suicidal in intent. And her peers spontaneously decided to surround her and to reach out and to comfort her, and also to connect her up with psychological services. And fortunately, she got back on track and seemed to be doing quite well. You know, this was not something that was orchestrated by outsiders, but by caring youth. And I'd say that we don't take adequate advantage of the enormous creativity and problem-solving ability of youth. Nor do we pay attention sufficiently to cultural resources. Some of my initial work in mental health and psychosocial support was on reintegration of former child soldiers in Angola during that long and bloody war. And I remember vividly, some of the young people said things like an Angolan boy who was 14, and he said, I can't sleep at night. And my Angolan friend, Carlindo Montero, asked, why can't you sleep? And he said, the spirit of the man comes to me at night and asked, why did you do this to me? And it turned out that that belief, which was very prevalent in his own community, made communities stigmatize and have him and have great fear of him, because the belief was that the angry spirits could jump onto other people and kill them or cause illness or other problems. And so in our work, we actually began working with traditional healers and building in traditional rituals believed to cleanse former child soldiers of their spiritual impurities. So I think that we need to engage much more deeply with local beliefs and practices and with non-formal networks. And I'm eager to say that these complement top-down approaches. I'm not at all suggesting throw out top-down approaches, which are absolutely necessary in acute emergencies or in situations that are too dangerous for participatory approaches to occur. But I think what I'm calling for is more power and decision-making by local people, more space for local people to collectively problem solve, and to identify the problem, to plan collectively for action, and then to take collectively action that's their own rather than that of outsiders. And when we do this approach, we need to recognize that sometimes local people will not want to start by talking about mental health and psychosocial support. They may be much more comfortable talking about youth development, well-being of children, and I think it's important for us to be flexible about this. And then I want to, at the same time, while I'm emphasizing the importance of localization, I wanted to caution and to add a critical note there. Every locality has a power elite. Every locality has structural violence, and people who are positioned in power and people who are positioned differently and who are left out. It would be very sad if in our movement towards localization, we did not take really powerful concerted steps to be very inclusive and to bring in the voices that have historically and at present been ignored and marginalized. So to conclude, we need a transformational process of rebalancing north-south power. We need to enable greater local community-led action and resilience. This is very congruent with the emphasis on self-help that are in the IISC guidelines themselves. And we need to better support the mix of leaders, epistemologies, and systems that will support mental health and psychosocial support in humanitarian settings. And of course, to do all this, we people from the global north will need to work with greater humility in a spirit of co-learning, and to maybe put down the expert mantle and maybe recognize that perhaps our better role is as facilitators. So I'm going to stop there. We can begin by taking a look at some of the questions that are coming in from our audience. So one from Fatiha is, what is the impact of the shielding measures, no touch, no hug, no kiss, on the children's mental health and the psychosocial trauma that may cause? And then a question from George Mullins. The PANC has highlighted of the already existing inequalities. How can we further support medical practitioners? So would anyone like to comment on either or both of those?
Thanks, Mike. I'm happy to respond quickly to the question around physical distancing and the impacts that it has had on children. And certainly, I mean, in the talks that we've all given, we've spoken a lot about, you know, the supports that are needed for children to survive and thrive. We talked a lot about the social ecological model that essentially is supportive of child's well-being, and that without the social support, without the linkages and the interactions with peers, the supports within schools and communities, though in absence of those things, the children's well-being is certainly impacted. We also, you know, saw with physical distancing and quarantine measures that our own services were disrupted. So a lot of the children, especially in humanitarian settings, who already were being challenged through their existing situation, and were struggling with mental health and psychosocial issues, we saw that, you know, that came with challenges as well. You know, I think the biggest learning and the biggest drive, and I think Fahmy articulated this very well, is that, you know, during COVID, is realization that there's so much that didn't exist that needed to develop and develop very fast. And one of the most important pieces, I think, was around helping to NYHQ programs to be able to reach those children and families. Especially, for example, when we're in humanitarian settings, for children on the move, for example, who are in fact a population that is already very hard to reach, irrespective of COVID. So there was this important learning that really pushed agencies and governments, especially in humanitarian settings, to develop these new ways of working and innovative strategies, not just digital, to reach those who are most in need. And sadly, this is not, like, as I mentioned, new to humanitarian emergencies, but beyond COVID. So the impacts are very real. And I mentioned earlier the impact that it has had not just on children, but on caregivers' own mental health and well-being, who have had to, in addition to their, you know, natural caregiving role, they have had to become teachers. They've had to care for family members who are sick, and they've had to, many have struggled with loss of employment, and so on. So all of these really compounding factors have certainly not been easy on our children and our families.
Thank you, Zeinab. And would anyone like to comment on George's question about the pandemic has highlighted existing inequalities? How can we further support medical practitioners?
Yeah, indeed, great question, and happy to step in and take this important question, Mike. And inequalities in mental health services, unfortunately, do exist even before COVID-19. So access to mental health and psychosocial support actually would be different depending on where you live. Such services would be highly developed and existing in high income countries, either within health and social sector, but but unfortunately these services would be almost non-existent in many countries with low resource settings. If we talk about specialized services all around the world, it's one mental health professional of any cadre, psychiatrist, social worker, psychiatric nurse, or psychologist for every 10,000 people. But if we talk about specialists in a place like South Sudan, the rate is 1 for every 4 million. A person who needs service and is based in the state of Malakal need to access the only existing service in Juba by traveling every week something more than 1,000 kilometers. COVID-19 has emphasized this inequality, and unfortunately we see this in mental health services. For example, within health sector, in a WHO survey done between January and March this year, among all essential health services, the service which was reported as number one, most disrupted, commonly reported, and most severely disrupted as reported by countries was actually mental health services among all essential health services. And if you zoom in within the mental health service disruption, the most disruption were for the most vulnerable groups. So the most disrupted service among mental health services was actually school mental health services. Disruption of services, which is unfortunately against those who actually need the service most, the most vulnerable, vulnerable group. So I think in addressing the continuation of mental health and psychosocial services and scaling up, we need to be careful of these issues.
Thank you, Fahmy. I'd like to add just a comment on how can we further support medical practitioners. In many countries, the US, India, practically all countries are seeing very severe stresses and strains being placed on health workers and also the staff workers who populate and clean up and do the burials. And I think that there has not been a very concerted effort to recognize that we need to help the helpers. And it's not always clear exactly how to do it, but I think that these are very long-term issues. The kind of burnout that we're seeing in the United States is something that could have long-term repercussions. And I think that in a place like India, it could be absolutely devastating because in addition to people actually getting healthcare providers getting COVID, and not being able to provide services, others are going to suffer emotionally and spiritually. And so we have a big task ahead in this regard too. So we still have about four minutes left. Ananda.
No, I was just going to jump in on that last point as well, just to say that I think in the face of inequalities, this overwhelming kind of set of needs, I mean, we are in the unfortunate position that we have to prioritize where we invest support. For example, healthcare workers who are not only experiencing hugely risky and hugely kind of emotionally difficult work, but also often in certain contexts are experiencing stigmatization and kind of fears around actually being able to return to their families and keep their families safe and so on. I think, investment in not just access to counseling services but also investing in safe housing mechanisms by which they can be sure that their families are safe, they're sure that they have enough resting areas, managing shift times to make sure that people are not burning out. There are certain sort of, I think, structural things that we can do. I also think that in terms of inequalities, I mean, my experience really resonates with Fahmy's in terms of, in Sri Lanka, for example, we have, counselors, usually one counsel distributed at the rate of sort of one counsel to several tens of thousands of people. But during COVID, they couldn't get to their officers, people couldn't reach them, and many counselors actually were unable to support clients who they've been in touch with over phone because, for example, they didn't have a good enough phone connection. They didn't have privacy in their own homes in order to be able to provide that kind of support. And they also didn't necessarily have the training, the skills that they had in a face-to-face setting to a remote one. And it's been useful to have kind of resources produced by colleagues around the world that we've taken and adapted and made relevant for local, and that has been really helpful. But still, there are sometimes these insurmountable infrastructural issues that I think we need to address, and so that I think we can't get around those entirely, and we need to. There is a real need for investment there.
So I think that is a good comment, maybe, to wrap up this session on. And I wanted to thank Fahmy, Zeinab, and Ananda for your very thoughtful comment. Together, I see us as having outlined an agenda, probably for the next 20 or more years, that has to do with really addressing inequalities head on, and doing it through the everyday and the social aspects, not just in the clinical aspects, working harder to develop concerted approaches and multi-sectoral approaches, multi-systemic approaches that bring in and awaken the voice and the resilience of children, families, communities, and whole societies. So from this vantage point, mental health and psychosocial support in humanitarian settings is everybody's business. It's not just the business of psychologists, psychiatrists, and social workers. So I hope everyone who has participated and hopefully has learned a little bit and gotten some new thoughts, and maybe can do your part going forward in trying to keep this issue uppermost on the agenda and to help us construct it in a way that addresses these issues and challenges that we've raised. Thank you very much, and thanks again to the organizers.
Thank you.
Thank you, Mike.
Thank you, Mike.
Bye, everyone. Thank you.